Semua dah ada dah? Ready? Ada semua?
Ada, doktor.
Seorang lagi, Datuk.
Siapa tak ada? Siapa yang tak ada lagi? Go leader siapa? Go leader.
Saya ada seorang student dia share device.
Dia share apa? Device. Siapa dia share device tu?
Sebab on the way balik daripada hospital.
Share device ni siapa?
Alia Najwa. Alia Najwa share device dengan Nurina Imani.
Okay, my lecture today is respiratory distress in newborn. So easy respiratory distress, and it happen in newborn. Newborn dia tahulah kan, selepas dia lepas lahir newborn. Okay, the key is newborn respiratory distress. Okay, there are many causes of respiratory distress in newborn. One is respiratory system, cardiovascular system, central nervous system, musculoskeletal system, and metabolic system. Metabolic problems. So you see the main thing is respiratory lah. The respiratory is the main system that involved when it comes to respiratory distress. Though other system can also contribute, cardiac, neurological, and other miscellaneous. The respiratory started from airway problem, airway obstruction, like the main thing is this laryngomalacia, laryngomalacia mainly, or disorder of chest wall and diaphragm, malformation of mediastinum and lung parenchyma, Ehrlich syndrome, pulmonary parenchyma vascular disease. There is a respiratory problem. The other are cardiac. Cardiac, there are many, cyanotic, acyanotics. And then the cardiac, the main common one you need to know is TOF, for cyanotic, TOF and tautology of failure. Two things. This is the thing. The rest you just know and know sajalah. And acyanotic, mostly you have to know. Acyanotic, they got respiratory failure, respiratory problem because of when they are in failure. The main thing is the main thing is you need to know is PDA. But the other one like VSD, ASD, they come later, not immediately after newborn. And neurological, like birth trauma, intravascular hemorrhage, meningitis, HIE, hepatic ischemic syndrome, and this is the main thing. And then other, the sepsis, anemia, and those, the respiratory distress. So respiratory distress, though the main problem is the respiratory system, but other systems can contribute, affect the respiratory distress. Example like the cardiac disease. When they develop cardiac disease, because severe cyanosis or severe failure, the child can develop respiratory distress. But you have to recognize the sign. Sign, I always say this, the term of severity. Look into the severity, mild, moderate, and severe. Mild, they just have tachypneic, tachycardia only. Moderate, they can have subposterior recession, alanacea, you tahu alanacea, hidung kempang-kempis. Severe cyanosis, grunting, drowsy, and comatose. The sign of respiratory distress. The other signs that you can get ialah poor and not tolerate feeding, inactive, poor perfusion, hemodynamically unstable, stridor and wheeze, listless, and temperature instability. This is the sign, but the sign in terms of severity is mainly this is the sign that can tell you how severe is this patient in the respiratory distress, and this is the causes, and then this is the system that get involved. So the treatment wise, respiratory distress, always ABC, secure the airway with suction, positioning, bed and mask on. If the child need intubation, you intubate. Look for the breathing. The breathing effort is good or not good, and then circulation, blood pressure, and perfusion, and treatment the specific causes. So always in respiratory distress, ABC first. When you come with anything, with questions, or when you meet any when you go to the delivery room, or when you see wherever the patient is, always think about ABC. ABC mean the airway, breathings, and circulations. It's good if you can have this second nature in your mind. Many of you, where something happen in front of you, you panic. Betul tak? Panic, stumble, stunted, and you're not sure what to do. So if you have this inside your mind, subconscious level, it just automatically, you know, when you look, anything happens, somebody call for help or whatsoever, look for the airway first, breathings and circulations, automatically. So you not stumbled. Ini kan medical student UIA, tengok patient, they be choking in front of you, you semua dia dah start. What to do next? What to do next? But people expect you to be able to do something. Especially kalau you bawa everywhere name tag, you are a student medical. Medical dia tahu semua benda, dia expected. So you have to know how to do the neonatal resuscitation. For the year 5, we're going to introduce to you the neonatal resuscitation. So finish lecture apa ya? Apa you nak tahu? That's all for year 5. Apa dia? Habis. A little bit about anatomy. This anatomy of the respiratory system in the baby, nasal cavity, pharynx, epiglottis, larynx, bronchus, left lung, right lung, pleura, diaphragm. So you got the bronchioles and the alveolar sacs, the respiratory system. We're talking about respiratory distress, we're talking about the respiratory system. Okay, let me get a bit more detail. So with respiratory problems is the commonest cause of mortality and morbidity. I think you all know, you go to the ward, you go anywhere, even you go to SCN and ICU, main problem the patient, the child, the patient, the baby had was usually is respiratory problems. The other will be sepsis. So a little bit about the developmental of respiratory system. Okay, when it comes to the lecture like this, that doesn't mean you need to have file. Some thought that was given a lecture, so you need to know and to memorize it. Don't worry, I also didn't memorize it, but just to get know of it. Many of you become a little bit extra panic now. So respiratory system development, you have to look embryonic phase, pseudoglandular phase, canalicular phase, alveolar phase, and after delivered, the alveolar develop, become increase in numbers until the age of 8 years, and after that, the size and diaphragm increase until adult, until you reach adulthood. So that is the respiratory system development, and that is the embryonic, pseudoglandular, canalicular, circular, alveolar, and start the bronchi, this generation, bronchioles, terminal bronchioles, respiratory bronchioles, alveolar ducts, and alveolar sac. So this conducting zone and transitional respiratory zone. Then how is it in terms of the formation? The embryonic is the first few weeks of life, formation of major airways, and then pseudoglandular, this is where organogenesis, and then the first 16 weeks of the intrauterine is a organogenesis, then after that differentiation. So the key important here is the surfactant. You need surfactant to have a proper function of the alveoli. So the surfactant is being detected at the age of the intrauterine more than 24 weeks, when the fetal is more than 24 weeks. That's where you can detect the surfactant, and then after that, then this become after birth, then the 6 weeks considered as the term, and at this stage is where the 26 weeks is where we say that it's a bit safe for the child to the fetal to be delivered, the baby to be delivered, because the surfactants start to be produced here. So a little bit about the commonest disease in respiratory distress in newborn. The most important one that you need to know to understand the respiratory distress syndrome, RDS, arterial membrane disease. This is because this insufficiency of the surfactant. Insufficiency of surfactant. And surfactant is a phospholipid, prevent the alveoli collapse, not airway, alveoli collapse. The risk factor is prematurity, male sex, perinatal asphyxia, maternal diabetes, antepartum hemorrhages, cesarean section, and diagnosis by X-ray, management and respiratory support, fluid electrolytes, acid-base balance, antenatal steroid, and surfactant replacement. The key is the surfactant replacement. How does surfactant work? You see, surfactant, surfactants increase the pulmonary compliance, reduce the effort to need to expand the lungs, and reduce tendency for alveoli to collapse. This surfactant is produced by the type 2 cells, type 2 alveolar cells. This is the respiratory bronchioles, this is the alveoli, and then this is your type 2, and this produces the surfactant. And then how it works, it works at the interface between the fluid and air. So it expand the make sure the fluid, this is increase the tension, surface tension here, and then prevent the alveoli to collapse. So let the air and then air, the gas exchange occur at this region. That's the function. So what happens if not surfactant? This will happen to the lung. It becomes solid, alveoli will collapse. We call it like liver light. Liver light, that's liver, but actually it's the lung. Because the lung becomes solidified because the alveoli is collapsing. And this X-ray, notice the X-ray or not? All white, is it? And there's some bronchogram. That's all. This is very severe type of RDS. This type 4. Nothing there, no air. And usually this is very difficult to treat this kind of patient because they no place, no alveoli for air exchange. Carbon dioxide and oxygen to be exchanged. And the result is many of these patients need to be ventilated, just to be supported. And the key treatment is the surfactant, artificial surfactant. One of these Saventa. There are a few more. The key treatment is this. Last time when we don't have this, many baby dies. Many children, babies, newborn die because of the events of the artificial surfactant. Result in many babies survive, and we can go even 700 gram, 800 gram can support. Yes, sometimes we can go beyond that to support those baby who are very, very premature. This one is probably 1 kilo baby. This one probably 24 week, 25 week baby. The other one is congenital pneumonia. By definition, you all know already, kan, congenital pneumonia. The most common is group B streptococcus, but the other bacteria can involve with Listeria, Klebsiella. The risk factor is maternal fever or maternal having infection, especially UTI, chorioamnionitis, premature rupture of membrane, prematurity, colonization of the delivery tract by group B strep. Treatment, of course, the antibiotics, especially the CPAN. And then transmission for congenital pneumonia intrauterine can be hematogenous, ascending, or aspiration. So the sign and symptom, when the baby come out, they can have tachypnea, retraction of the intestinal muscle, intercostal muscle, grunting when exhaling, nasal flaring, increased mucus or fluid substance in the airway, can be yellowish, greenish, sometimes hemorrhagic, unstable body temperature, poor feeding, abdominal distension, jaundice at birth, glucose intolerance, hypoperfusion, oliguria, and cyanosis. That is especially the central cyanosis. And there is an example of chorioamnionitis, the ascending from the tract, delivery tracts, from the cervical, go up into the vagina, cervicals, and go up and get infected to the baby. It can be hematogenous also from the blood surrounding his mother got infected. And this is the X-ray. It's a bit different from the first X-ray. The first X-ray you look quite solidified, is it? Very solid. The second X-ray you can see the more softer consolidation. More softer consolidation. So this one is a congenital pneumonia. The other one is TTN, Transient Tachypnea Neonatal. It is one. It happened in large preterm or term, and 1 of 2% of the term can develop TTN. What happens is that, you know, the lung, intrauterine, consists of mainly what they contain, fluid. Fluid. During delivery, crying, absorptions, the fluid will be taken out from the lung. The lung will be dry, but sometimes it takes time. It doesn't occur as fast as we want it to happen. So the fluid has not been, the lung is not been dry fast enough. The result is the lung is still retain some fluid inside the lung, and this result in physiological affect the lung to function properly, and that's we call it. And because of that, they become tachypnic, they become grunting, they have respiratory distress, and this is what we call transient tachypnea neonatal. But because it's transient, because after a while the lung will dry, because of especially the absorption, so it rarely persists more than 40 hours. The main contribution is cesarean section, because when the child go through the delivery tract, usually it takes time. The phase 2 will take time, few hours, and during that time, the child, the fluid in the lung will be squeezed out, and the child come out cry. And when they go to the birth canal, you know, birth canal. But when you scissor the child, you don't go through that process. The child come out just like that, and you take out, and then they cry, and then quite a short time, as a result, lots of fluid can still retain inside the lung. And the X-ray finding, usually you can see the water in the fissure. You call water in the fissure. It is water in the fissure that told us that the lung, this is a large amount of fluid still inside the lung, and result is in the child, the baby, newborn, having neonatal respiratory distress. Okay, the other one is very important one is Muconium expression syndrome. You heard Muconium? Muconium is a fetal GIT secretion, consists of epithelial cells, hair, and then the secretion. Muconium cause obstruction and pneumonitis. The risk factors mainly is post-term baby or baby with asphyxiated. The future is the life cord, we can meconium stem, and then there is evidence of respiratory distress. Treatment-wise, more prevention, avoiding the child or the baby, the newborn or intrauterine fetal having respiratory, having distress inside the intrauterine, and the treatment, that's mainly the treatment, the prevention. If the baby born with a lot of meconium, then there is certain procedure we can do to minimize the meconium to be aspirated inside into the lung, and this is the meconium. You can see it's very sticky, very sticky. Imagine this thing stuck into the newborn airway and newborn lung. Newborn lung. You can imagine this one very sticky. And not only that, it's very corrosive. It can it's big corrosive, and when enter to the lung, it causes a reaction to the lung. We call it pneumonitis, inflammation of the lung. Then the physiology is more complex than that. Just to understand that it doesn't straightforward. But meconium aspirate syndrome, there are a lot of pathophysiology involved. You see the X-ray. The X-ray is more a bit hyperinflated. You can see not much consolidation, the air here and there, but the air is not homogeneous. Hair here, this one is some consolidation here, air here, air not homogeneous, because the meconium block is not homogeneous. It's not the same at the same area. It can be different. Some thicker this place, block here, this one not block. So it doesn't homogeneous on the X-ray. And you can see also it's a bit upper inflated. The X-ray it show you that there is an airway block, and then after a while they become more whitish because of the pneumonitis. The other one is pneumothorax, pleural effusion, pulmonary hemorrhage, and then there's some congenital anomalies, hypoplasia of the lung, sequestration of the lung, congenital deformity, hernia. What is this? Anybody?
Diaphragmatic hernia.
You can see here, it's in the lung. It is the thoracic cavity. Thoracic cavity. You can see there is a guts, intestinal and guts inside the thoracic cavity, and the lung here are small, is it? And then the heart is being pushed to the right side. So this lung also small. This is a severe deformity hernia. And then you can see what happened to deformity hernia. The diaphragm didn't fully develop, resulting there is a hole here, and then through this the GIT, the duodenum, the intestine can go through into the thoracic cavity. You see the X-ray here. You can see here on the left side. Here you can see the lot of air bubble that show to you the GIT tracts enter into the thoracic cavity. Here is more better diagram, illustration, more better illustration. It's very still. This is one type. The child can. This is the kind of, sometimes what happens is that we don't diagnose early. We diagnose after accidentally when we did the X-ray, because the other thing we found that there is a air, bowel air, because it very small amount of intestinal only. They can come after a few years of life. And this one, anybody? Sorry. Anybody? This X-ray, anybody can figure out what is this?
Tension pneumothorax.
Yes, this is a pneumothorax. It can happen. It is in baby newborn. This is a pneumothorax. For many reasons, the baby can develop pneumothorax. So you can see this air into pleural space, and then it push the heart to the left side, right side. This child coming with slow respiratory distress. Treatment was easy, just put a chest tube. Sometimes you put the needle first to expand the lung. This one, anybody? You can see the X-ray or not? You can see here some abnormality, is it? No, it looks like full with air, but doesn't look like solid, full like this, is it? This is nothing but air, but this one there's still some tissue, little bit tissue, but you can see it push the heart to the one side, to the right, to the left side. This is the knee. You can see this from CT scan. On the right side, something big here. Abdominal tissue full with air, nothing else, air only, no lung tissue at all. This is congenital ability, we call it CLE. Congenital lobar emphysema. Lobar emphysema. Adult, for the smoker, you can see, for children, newborn, they can develop abnormality of lung like this. Lobar emphysema. This one is the most easy. We just cut it out. In this one, anybody? On this X-ray, on the left side of the lung, there is a big mass here. Notice or not? Big mass. Compress the lung on the left side. Even compress the airway here. Result in respiratory distress. This is bronchogenic cyst. Ini, anybody can suggest anything?
Lung collapse.
Lung collapse, not so much lung collapse. This is different. The lung are very small, is it?
Yes.
But right, it's supposed to be until here, but it's only at the half of the thoracic cavity. This we call lung, bilateral lung hypoplasia. Bilateral hypoplasia. This is how the lung, see the lung very small, is it? So even compared to the heart, the lung are very small. The bilateral lung hypoplasia. It's very severe like this. Difficult for a child to be survived because it's not treatment. It's very severe because the lung have not enough capacity to sustain life. This is another abnormality. This airway abnormality. That you're talking about the lung. The airway abnormality can be stenosis, laryngomalacia, or tracheoesophageal fistula. This is type of tracheoesophageal fistula. There are many types. And the other one is the cardiac problem. Cardiac is congenital heart disease, or cardiac failure, cardiomyopathy, persistent fetal circulation. The one that you need to know is the heart failure, and then the congenital heart disease with severe cyanosis. This is the one that causes respiratory distress in the newborn. The other type is muscular. Muscular. There are many types. One is the SMA. You know SMA, child flaps, SMA types, where there is the child is flat, and then because of there is very there's spinal muscular dystrophy. The spinal is defect, result in there's no nervation or nerve atau isyarat nerve conduction to tell your muscle to contract, not to contract, contract or not. So you just flat like that. Your muscle didn't contract. So you know that you need your muscle to move your respiratory system to function well. This one spinal muscular atrophy. This is we're talking about the muscular muscles. So go back to the causes. You can see the causes, there are many. Many neurological, other cardiac, and then the main thing is the respiratory disease, the causes. So you must able to assess in terms of severity, because your management depend on the how severe is this. Mild, sometimes we just observe, we treat accordingly with the antibiotics. Moderate, perhaps the child needs some support like CPAP or BiPAP. Severe, usually they need a very high level of support, intubated and ventilated. And then so the management at the end of the day is the assess your ability to assess the conditions, how severe is it, and then able to decide what the causes. But important is that you must able to do the immediate management, especially the ventilation support. You mean the airway and the breathing. Then later you decide what circulation, and only then, after you have do all these three, you stabilize the patient, you will treat the main causes. The main causes, as I discussed earlier, I'm unable to give you all the causes because it is safe in one whole book, but then there are many causes, but the one that I discussed with you consists of 90% already of the causes. But you must realize that in your clinical practice, in your clinical skills, is ability to assess an immediate management. Then that's why you have the neonatal resuscitation training. When you come to us, we train you how to resuscitate this kind of baby. Any questions?
Dato, I have one question. How to differentiate between respiratory distress syndrome and congenital pneumonia clinically?
Yeah, first history. First history. You see, the respiratory distress syndrome mainly occur in the premature. Premature, mainly because of the surfactant deficiency. Once it's here, but right, you don't have any more RDS. Rarely you have RDS after the 36 week. Usually even 34 weeks. So usually surfactant is considered to be adequate. Usually beyond this, you will need surfactant is not enough to sustain to open up the alveoli, and thus you need surfactant artificially. So the main thing is the age of the neonate. If you're premature, most likely you are RDS. The other issue, the other thing is the symptom, the sign symptom, the history is mother have fever, mother having UTI, mother will swap to have strep, and then likely is also due to infection of the congenital pneumonia. The other is the systemic symptom. The systemic symptoms is you have this systemic symptom of unstable temperature, abdominal distensions, glucose intolerance. Usually it tell you that probably the child having sepsis, and then this pointed out more to the congenital pneumonia. Any other questions?
Doctor, is there any role of corticosteroid in treating respiratory distress syndrome?
We don't use corticosteroid to treat RDS. We use surfactant. We don't use. If we do give the mother before delivery, those with severe premature mother, there's still contention issue. Some people don't think it's necessary. Some people think it's we need to give. We need to give. Some people say no need to give. They are contention issue. But then we think that steroid we don't use for RDS per se. We use surfactant. Any other questions?
Dato, sorry if I ask too much question. How can we know hyperinflated lung in X-ray?
You have to look into the X-ray. You look at this like this X-ray kan. You can see the diaphragms, and then you calculate 1, 2, 3, 4, 5, 6, 7. It should be by 5 here. Okay, but this one you can see. Yeah, you can see the apa tu. You have to calculate the bone, the sternal bone, you have to calculate. First you see the X-ray, how dark is it, and then you have to calculate usually the posterior. What is bone? This is the rib. The rib. You have to calculate the rib. You have to calculate the ribs, and that this one by 5, it should be here already. Here. But then you can see that you can see until 1, 2, 3, 4, 5, 6, 7. So by right only 6 only. 6, 7 into here. And then you see the diaphragm. Diaphragm is flattening. Flattening of the diaphragms. So this is indicator to you that it's hyperinflated chest. Okay, anything? Finish. Okay, simple je. Though it's simple, you should know some of it. Some of it you just know only. That the development, the organogenesis of the lung, progression of the lung, you just know about it. No need to memorize it. Okay. Okay, finish.
Thank you, Dato.
Thank you, Prof.
Okay.
Thank you, Doctor.
Thank you, Dato.
Thank you, Doctor.
Doctor.